and all of these emotions from that other side. And I think that we can learn a lot from that type of experience as well. So we've heard from the family in terms of communication. We've heard about the difficulties that we have with regard to burnout. And now we will hear from the other side from Tracy as well. Thanks, Tracy.
Good morning, everyone. I'd like to thank Brian and the organising committee for inviting me to talk this morning. Before I get into the main part of my talk, I'd like to just tell you a little bit about myself. Like many of you in the audience, I was a very aspiring and driven medical professional. I was also an enthusiastic anesthesiology registrar, having completed my specialist training. I loved my work and I loved my profession. And because I had such a passion for anesthetics and intensive care medicine, I excelled in my field. I prided myself on keeping abreast of new developments, and I loved the practical aspects of the job even more so. I was also pathologically independent and most comfortable when I was in control. My husband and I were at a high in both our careers and in our personal life. We were both young, healthy, and very active. And to add to that, we were expecting our first child. As part of my registrar training and as a medical officer, I spent many months working in a number of specialty ICUs as the attending doctor. And I dealt with many different difficult cases. But nothing can prepare one for the unfortunate day when the tables turn and one finds themselves on the other side of the fence as the patient instead of as the doctor. 7 years ago, my life and that of my family's changed dramatically and completely in one day. I became a patient overnight, and not only did I experience the suffering of illness, but I also know now what it feels like to be severely ill, what it is like to undergo millions of investigations, what it is like to be in hospital, in high care, and in ICU, and more so, what it feels like to start life again, physically, emotionally, and psychologically. The purpose of my talk is to provide some insights into the world of critically ill patients, rather than a doctor's or nurse's perspective of that experience. I stand before you today to tell you about my very own personal journey. I became completely dependent, inactive, and critically ill, and no longer did I have any control over my life, quite opposite to the person I had always been. I spent most of my son, Luke's, first year of life in a wheelchair, much of his second, and then many months over the coming years. I also often have crutches, a neck brace, and joint supports as part of my accessories. I have undergone every possible investigation one can think of, and then a few more. Some of the investigations I had previously thought were non-invasive and thus not uncomfortable, but now from experience I know differently. I have seen more medical specialists, alternative therapists, rehabilitation therapists and other professionals than I care to remember. I have inhaled, swallowed, applied and had more medication injected into my system than I ever imagined possible. Through the past years of illness, I was bedridden for months at a time, oxygen dependent for years, and severely disabled for an extended period. Unable to walk and for years unable to drive, due to the numerous disabling events that I suffered. I am still classified as occupationally disabled, which made me truly reevaluate my life without my previously greatest passion, medicine. Needless to say, I fought long and hard to overcome the uncountable challenges and the physical disabilities that I faced. Over the years, I have learned a great deal, but one of the greatest lessons I've learned is that nothing in life is certain, and that circumstances change one. Prior to my life-changing events, I had been completely healthy, and the only complaint I'd ever had was in 2004 when I developed an idiopathic right optic neuritis. Numerous tests were done, and the only abnormal result was an incidental finding of a mild, slight protein S deficiency. So in 2005, when I became pregnant, I was started on prophylactic clexane. I was 3.5 months pregnant when I developed a right popliteal deep vein thrombosis. I was treated with bed rest, elastic compression stockings, and the clexane was immediately increased to therapeutic doses of 1 milligram per kilogram PD. 3 days later, the thrombus extended to involve the femoral vessels, and the clexane was further increased. A week later, on therapeutic doses of clexane, monitored with anti-10A levels, I suffered a massive right pulmonary artery embolus. I was in mid-sentence when I started feeling uneasy, quite unlike myself. And then a sudden, extremely severe, unrelenting pain in the center of my chest began, slightly to the left of my sternal margin, through to my back, and the pain consumed me. Initially, I didn't feel short of breath. It just felt difficult to breathe. My chest felt tight and heavy. And within seconds, I was overcome with extreme exhaustion, and I was drained of all energy. The days that followed were some of the worst days I'd suffered in my life. It is the first time I can say I truly faced death. I was hemodynamically unstable, and I hung on by threads, fighting to overcome the immense sense of doom and dread. And even though it was clinically obvious that I had had a massive and still potentially fatal pulmonary embolus, I was sent for an urgent CT scan. I had never had a scan before in my life, and never one with contrast, but I had ordered many on patients before, without a second thought as to how it felt or how frightening any investigation or procedure might be for them. I have since had numerous investigations, and it is never pleasant. Having investigations done is both uncomfortable and unfamiliar for patients. We tell our patients to relax, as it is not a painful procedure, but we fail to explain to them the overwhelming and foreign sensation one experiences, especially if intravenous contrast is injected. Immediately, one experiences a strange warmth and flush over the entire body as the contrast goes in. This is followed by an awful perception of tightness in the chest, and then the sensation as though one has urinated, which fortunately isn't true. The CT scan results confirmed a large pulmonary embolus at the base of my right pulmonary artery. I rapidly developed severe acute pulmonary hypertension, right heart strain, right heart failure, and my pulmonary diffusion capacity was markedly reduced. I had amazing doctor colleagues managing me, and had I been in their shoes, I would have advised the exact same. Immediate thrombolysis in ICU, if I stood any chance of survival. However, the only therapy that would, in all likeliness, save my life would also, in all likeliness, end that of my babies. And I was unwilling to take that chance. I just couldn't choose my life over that of my child. My doctors were very alarmed, concerned, and unhappy with my decision. They disagreed with me and felt I was being unreasonable, and perhaps I was. And that it was going to be a miracle if I survived. It is so ironic that previously as a doctor, I found it outrageous when patients refused certain treatments that were surely common sense. And I couldn't get over how bizarre and how irrational patients could be. Never had I imagined that I would one day be that same irrational patient. Without thrombolysis, the only option was to increase the clexane further to 3 milligrams per kilo, remain bedridden and on oxygen 80% of the day. From the moment I had the pulmonary embolus, there was not a minute in the day that I did not experience pain or respiratory distress, and I officially became completely dependent. Over the many months that I remained bedridden, on oxygen and clexane, I experienced numerous episodes that required a return to the ICU. The unstable angina that I experienced was typical, crushing, pushing pain in the center of my chest, but it also caused an awful choking sensation around my neck and a painful numbness in my jaw. As the pregnancy progressed, these episodes became more and more frequent and more severe. My numerous high care and ICU experiences were mostly similar. I was always critically ill, hemodynamically unstable, in pain, dyspneic, and my skin was blanketed in bruises and areas of subcutaneous necrosis from the Clexane injections. Having all monitors and accessories attached to one in ICU is not painful, but it is most uncomfortable. The observations, done every half hour to hour, sadly becomes the most important part of your day. My bed was generally directly adjacent to the nurse's station, and alarms constantly sounded, and the monitors on my own alarms were, the alarms on my own monitor were continually alarming. All in all, it is impossible to get any rest in an ICU. The early morning routine is like clockwork. At 4:20, the phlebotomist comes around, takes some more blood, all observations are done, another ECG, fingers are pricked. By 5 o'clock, the nurses want to get you up and bathed. And because I was always too ill to move out of the bath, that meant it had to be done in the bed. I hated being too helpless and too weak to even bath myself or brush my own hair. The twice daily bed baths were horrible. The entire act of being bathed by a complete stranger is most undignified. And more often than not, I would find myself completely exposed and quietly hoping that no one would just open the curtains, as often occurred. And if I needed the toilet, well, then the only option was a bedpan. I always felt uncomfortable and nervous using the bedpan. I was afraid the bed would get messed, and I hated it. It was degrading. By 6 o'clock, the intravenous lines are flushed and medication is administered. As a patient in the ICU, the days and nights seem to go on forever. And being in ICU increases one's anxiety. The longer one spends in ICU, the more disorientating the days become. It is a lonely and frightening place. One is surrounded by other critically ill patients. As the days pass, one sees other patients come and go. Many deaths occur around you, and everyone is constantly busy. I used to look forward to the visiting hours so much, yet when visiting hours came, it felt like chaos, and by the end of it feels that I'd seen everyone and yet no one. Other observations I made while lying in the ICU as a critical patient is that even the patients that are awake often have no idea what medication is given, when it is meant to be given, or for what reason it is being given. The doctors and nurses simply administer the prescribed drugs and are often either too busy or possibly they feel that the patient doesn't need to know what is being given, taking away much of the patient's autonomy. Another observation I made is that everyone, the nurses, doctors, physios, everyone, comes around and tells the patients that they're looking so good and they're doing so well every day. Yet more investigations and procedures are ordered and done, and hardly ever are the results shared with the patient. I strongly feel that it is essential to reassure and explain things to patients without frightening them, but ignoring or falsely reassuring increases anxiety and agitation. Even when I wasn't in ICU or high care, I was still exceptionally ill, and there were many moments that I faced death, and all I could do was pray for courage, strength, and endurance. Being critically ill for such a long duration is exceedingly challenging. 14 weeks after the initial event, I suffered a second new pulmonary embolus and was urgently admitted to the ICU for insertion of a vena cava filter and an urgent cesarean section. I knew all the risks involved and I was terrified. I had a general anesthetic with all the invasive monitoring and lines inserted away with no sedation. And even though local anesthetic was used, I felt everything. It is amazing exactly how uncomfortable and how painful the insertion of these lines can be, and yet we, as doctors, often get annoyed with patients for moaning or moving during the insertion of these lines. During the A-line insertion, I could feel the metal guide wire going into the artery and the cannula being passed over it. And actually, the worst part of the A-line was when I was in ICU, especially when it was flushed. And I've spoken to other patients who are in ICU who have had the same experiences. The pain that one feels during the flushing is quite tremendous. It spreads from the wrist down into the hand and the fingers, and it lasts for a couple of seconds each time. And often as medical professionals, we don't take any notice of that, or even think that that happens. When I had the left subclavian CVP line inserted, the dilation of the superficial tissues with the large dilator is exceptionally painful, and I suffered painful paresthesias down my left arm. As a patient facing extreme illness and unstable, I simply lay still while nurses and doctors took turns at doing what needed to be done, and it was frightening not knowing what was going to happen next. Awakening from the anesthetic, I was extubated, fortunately, and on a poly mask, but I had suffered a severe myocardial ischemic event in surgery, and I was transferred back to the intensive care unit. My beautiful baby boy Luke, who I only met many days later, was transferred to a neonatal ICU, intubated and ventilated, but in another hospital. He went on to spend 5 weeks in ICU, during which time he suffered RSV pneumonia, intraventricular hemorrhage, apnea, and jaundice. Fortunately, he is now a healthy, active, and bright young boy. My post-surgery ICU experience was possibly my worst. As expected, I was attached to every monitor and line possible, which constantly alarmed, and I was directly in front of the nursing station. During that ICU stay, it felt as though I was constantly having some or other test done, having the A-line or CVP lines flushed or fiddled with, the urinary catheter cleaned, emptied or repositioned, and the intravenous lines inserted, blocked, tissue reinserted. Even more dependent than previously, I now relied on the nursing sisters for absolutely everything, which was exceptionally demoralizing. In fact, when the urinary catheter was removed, I remember crying because it meant using the bedpan more frequently and thus a further need for help, as well as the additional physical challenge. Physiotherapy 3 times daily was my nemesis. I had physio for my chest and for mobilization. And even though the physio was an essential and necessary evil, I dreaded each session as I was left aching everywhere. The only way I found I could survive ICU was to detach myself. If I allowed myself to think about what was going on to me or around me, or the circumstances that I was in compared to where I had once been before, or how independent I had once been before, I'm not sure I would have survived feeling so trapped. Unfortunately, it is only once one has experienced such dependence, pain, and suffering that one can truly empathize with other less able people who have to endure dependence on others daily. A particularly bad day in ICU for me was when my condition deteriorated suddenly again, and I was extremely unwell. And even though I kept telling everyone that something seriously was wrong, the medical staff kept telling me I was fine. Maybe I just had baby blues. They gave me an antiemetic. It is so typical of us doctors and nurses to ignore or brush off a patient's symptoms or complaints, especially if we perceive that symptom as relatively minor, or if we are unable to give an explanation for the symptoms, or if it doesn't directly relate to our speciality. A few days into the ICU stay, my A-line was removed as it caused a thrombosis of the left radial artery with ischemia to my left index finger and thumb. My discharge from ICU unfortunately was short-lived, and 4 weeks later I was readmitted with endometritis, severe puerperal sepsis, septic shock, and cardiac failure. My left hand was still ischemic, and apprehensive to compromise the right radial too, the left was punctured again. It is impossible for me to accurately express or convey the immense, excruciating, and unbearable pain that I felt during that procedure. It was like a knife being put through my wrist, and the pain spread into my hand, lasting hours. It took weeks before I was able to touch or bend my wrist again. Discomfort was taking on a complete new meaning, and I experienced an episode of complete disassociation, or an out-of-body experience. I saw myself lying on the hospital bed with all the lines and monitors attached, and I looked weak and in agony, and I knew I was dying. That night was a constant battle of wills. There were moments I felt I could no longer fight so hard to survive, and I often questioned why I was praying to survive, considering that recovery was almost impossible. It felt easy to let go of the fight and to surrender to the suffering. But I had my family that I needed to fight for, that I needed to survive for. I never imagined myself ever saying in my lifetime that I had experienced a sense of doom, that my life had flashed before me, and that the end was tangible. But over those months, I had experienced many such familiarities. The critical illness itself had been extremely difficult to survive, but nobody warns one how much harder and demanding the recovery period will be. When we doctors discharge patients as well and recovered from an illness or disease, especially one that is complicated or prolonged, it is as though the battle has been won. Well, let me say that the recovery is as difficult, as painful, and as challenging to survive. If I were to go through all my complications, we would need hours, not minutes. The complications of the actual coagulation disorder, the DVT and pulmonary embolus, were extensive, and the complications of the critical illness itself were numerous and extremely disabling. My recovery was hampered by numerous setbacks, and the complications from the medication and therapy instituted were even worse than the original events. I was started on lifelong warfarin, and unfortunately my control is extremely brittle, with a very tight range of between 2.5 and 3. Anything above or below results in extreme disasters. I have suffered numerous venous thromboses and multiple intra-articular and intramuscular hemorrhages and other life-threatening complications and bleeds. If everything I endured was not enough, I still had varicella zoster on my face. Within a few months, it became obvious that in addition to the pregnancy triggering a coagulation disorder, that I had an autoimmune vasculitic disease, probably Behçet's disease, which caused a range of problems itself, some less debilitating, others crippling. In fact, the central nervous system vasculitis that I suffered rendered me unable to articulate appropriately, unable to coordinate muscle movements, confused, unable to tolerate noise or light, and I constantly had a tremor. The recent choroiditis and ocular vasculitis that I have suffered has left me with partial, permanent loss of vision in my right eye. Part of my management included the use of immunosuppressive therapy in addition to the steroids. And on azathioprine, I endured even more life-threatening complications. What makes one patient survive and another not? What determines our outcome? All questions we ask. I know that against all medical explanation, I did survive, and my attitude has been my greatest asset. I never gave up hope that things would be okay, that life's challenges make us stronger, and that as long as I was alive, I would never give up on my recovery. My faith has kept me sane and given me strength, and I'm filled with gratitude to God for my gift of life, for I was granted grace, and circumstance showed me a miracle. I smile and laugh a lot, it helps. I look for the humour in my circumstances, and I choose not to let my circumstances get me down. I remain positive. Life isn't always easy. Life's circumstances are not always what you wish them to be. It is not always possible to understand why life works the way it does, and life does not necessarily go as you planned. At times we lead in directions, possibly a direction you may never have imagined or dreamed, directions that are often beyond all understanding. But if one falls and stays down, then life will pass one by. My hope is to one day to return to my profession in some way. I now appreciate that the levels of great joy that one experiences or feels are proportionate to the depths of the hardships one has experienced. I take this opportunity to thank all my doctors who played an unconditional role in my journey, many of which are in the audience, and I also thank you for taking the time to listen to my story.
Thanks, Tracy. That really was good, and certainly very instructive for all of us, because we forget the discomforts that we sometimes apply, not intentionally, obviously, but that happen nonetheless. And we certainly hope that you will be back with us shortly, because you certainly have a lot to offer and a lot to teach us with
with what you've been through as well.
I think that we'll end on that point. Tracy will be around if people want to come and chat to her as well. I think that she showed incredible bravery, and I think that she's taught us an enormous amount. So thanks very much, Tracy.